Hello. Good afternoon, everybody. Happy Monday. Thank you for being here. My name is Shayla Carroll. I am a clinician with NJ4S. If you don't know, NJ4S is a DCF-funded program. It's a new initiative to help youth mental health. We do prevention programs. We do clinical services. So as a part of our kickoff and everything, we're starting some presentations. So we're starting off of a winter series, all focused on trauma and coping. So Monica Frank is going to kick us off. I am going to introduce her and then I will kick it over. So Monica Frank is a licensed clinical social worker, licensed clinical alcohol and drug counselor, and social work supervisor in the state of New Jersey. Currently, she is one of the clinical support supervisors for Prevention Links, offering supervision and consultation for both peer coaches and clinicians. Monica has been working in the behavioral health substance setting since 2006. She began working in substance abuse treatment in 2012, where her focus became more and more concentrated in the treatment of trauma and the overlap of trauma and substance use disorders. In the past several years, Monica has completed various trainings and certificates in the area of trauma-informed care and trauma-specific interventions. She is EMDR certified and an IFS-informed EMDR basic practitioner. She's also a yoga teacher that teaches from a trauma-informed lens with heavy interest in somatic work. Monica is also a lover of cats, yoga, playful movement, astrology, tarot, and most things fantasy related. She has a long to-be-read list, and the next book is Sorrowland by River Solomon. So it is my pleasure to introduce my supervisor, Monica Frank. Thank you, Monica, for being here, and you can get started.
All right, thank you. And thank you everybody for being here and taking time out of your day to be a part of this presentation. I'm going to go ahead and share my screen while I do this. All right, so here's who I am. Thank you so much for that bio. One of the things that I forgot to include in there, I do have a few different jobs. One of the jobs that I do have a therapy job. I work for a practice down in Burlington County, New Jersey. I always like to say I'm going to completely take over New Jersey. I have plans in Union County, also in Essex County and Burlington. So my takeover is imminent. So I see about 15 clients per week, and I do specialize in substance use disorders, complex trauma, as well as dissociative disorders. Here's just a little bit more about me. So the objectives for today, we're going to talk about really what is trauma. We're going to have a few different definitions of what trauma is, how it impacts people, how it presents in people, and why trauma-informed care is important. Just a note, if you see me looking down here, it's because I have some of my notes down here. And I'm looking at this a lot through the behavioral healthcare setting lens. So things to know during this presentation. First, meaning this is a 5-part series. So a lot of what we cover here is a broad overview. I really encourage everybody to attend all of the presentations. It will be 5 weeks. A lot of these are going to flow into one another. So I might start to talk about something here today that's going to be followed up next week and the week prior. Take a breath. So these are heavier topics that we are jumping into. It's really important that you acknowledge if there's anything coming up for you. If you find that any of this information is particularly heavy, just to make sure that you are taking care of yourself as well. The format of today, I'm going to have a few slides. I'm going to show a short video clip. We're going to go through a lot more slides, and then we'll have time for questions at the end. If at any point during the presentation you really have a burning question that you want to ask in that moment, please just raise your hand and I'll answer it. I also don't like to hear myself talk for long periods of time, so I will welcome that. And finally, take what you need and leave the rest. This is really an informational session for all of you, so I encourage you to, if there's a part of this webinar that you really like, to maybe do a little bit more digging into, and if there's some of the information you're like, I don't need, that's okay too. Alrighty, so that being said, we're going to get into it. What is trauma? I really love this artwork. Just so you know, this is the Twisted Rose. It's by Andy Farr. He did a whole collection talking with people who've experienced trauma and who have a diagnosis of PTSD. So this is one of the artwork pieces that he created. So trauma has a bunch of different definitions. According to SAMHSA, trauma is an event or series of events that is experienced by a person as physically, emotionally harmful or life-threatening, that has lasting adverse effects on an individual's function and well-being. So mental well-being, physical, social, emotional, and spiritual well-being. Peter Levine, who is the author of Waking the Tiger, and I believe is the founder of Somatic Experiencing Institute, defines trauma as this: it is anything that our system can't handle or process. It is not what happens to us, but what we hold inside in the absence of an empathetic witness. And what I really appreciate about this definition is it talks about how you can have two people who experience the same thing, but if somebody has the internal and external resources to process it in a way that is healthy and supportive, they may not experience signs of trauma. They may not develop symptoms of PTSD. However, if you have another person who experiences the same exact thing, if they don't have a lot of internal resources, if they don't have a lot of external resources and support, they will then experience the event as a traumatic event. We do not get to say what is traumatic for somebody else. And I want to stress this. We never get to decide what is traumatic for somebody else, right? It is the person who experiences it as a trauma, and that lives within their body and their mind. So I'm going to give you a couple of different definitions. This is from complextrauma.org, their glossary. I just kind of want to say that there are so many different types of trauma that you may have heard of. I'm not sure what everybody here does for work or what spheres you're in, but there's a ton of different types of trauma. I'm just doing the most basic ones here. So acute trauma. And this is often something that when people think of trauma, they think of this, an acute trauma. It is a singular traumatic event that is brief in duration and narrowly focused in nature. So something like a car accident, an assault, being a part of like military combat. Traumatic stress or event, which is very similar to an acute trauma. Again, it's a distinct and specific incident. However, the difference between an acute trauma, this can be standalone, or this can occur as a particular episode of an ongoing traumatic experience, right? So I mentioned that acute trauma can, say, somebody who's in the military who is in combat and experiences, a really big event in combat. That is an acute trauma. However, if they're in combat for a long period of time, what they're experiencing there could be felt as traumatic stress. Other examples of a traumatic stress or traumatic event could be, again, an assault, ongoing assaults, ongoing bullying, an unexpected death, any type of other natural disasters as well. Here, and if you're in the trauma world at all, or the mental health world at all, you might hear big T versus little t trauma. Big T trauma, and again, I try to steer away from that type of language because it often minimizes things that are classified as little t trauma, and those, we don't want to minimize those. Those still have a very large impact on a person in the community. But big T traumas, specifically, they're usually occurring to acute traumas. Little t is often referring to traumatic stress or complex trauma. Complex trauma, I gotta move this little thing to the side here. Complex trauma is an integrated term that encompasses both the exposure to multiple chronic or recurrent traumatic experiences and the wide-ranging and long-term impact of these experiences. So next week, Shayla is going to be doing a presentation on ACEs, adverse childhood experiences. The higher the ACE score, the more likely that a person is going to experience complex trauma. One of the things that I do want to say about all of these types of trauma that are listed here on the screen, it doesn't necessarily have to happen in childhood, right? So you can certainly have gone through some adverse childhood experiences, have experienced complex trauma, but maybe you didn't as a child, and maybe you are a person who, the older you got, you started to experience more traumatic events. or ongoing traumatic stress or traumatic events that led to complex trauma, right? So this is something that can happen across the lifespan. Complex trauma, again, emphasizes difficulties arising from a person's efforts to endure and adapt in the face of adversity. Complex trauma and looking at complex trauma from a trauma-informed lens provides a strength-based, survival-driven reframe of trauma. Some of the other categories of trauma that you might hear are developmental trauma, interpersonal trauma, racialized trauma, ancestral intergenerational trauma, and then again, if you're working in the behavioral health field, vicarious or secondary trauma. All right, so this means take a breath. Go ahead and look at those puppies and how cute they are. You're gonna see these images kind of sprinkled throughout the presentation. One of the reasons that I do this and why often I've been in presentations that other presenters will utilize pictures like this is things might have come up for us while we're talking about trauma, right? While we're talking about some pretty heavy topics. So there is research that shows that looking at something honestly particularly cute, looking at something also that is based in nature that can kind of give us a sense of awe, does something to our nervous system, right? Kind of brings us a little bit of a sense of calm, a little bit of a sense of, ooh, I kind of like that. And it does something inside for us physiologically. So that's why these are sprinkles in here. So how does trauma impact people? So I'm going to stop my share real quick and pull up a different screen. So we're only going to watch about 3 minutes of this video. This video is easily found on YouTube. It is one of my favorite videos to share with people. Hold on one second. Okay. Okay, and then Shayla, when I turn this on, if you can just let me know that you hear this. We're good.
Over half of us have a chronic disorder such as high blood pressure or autoimmune disease. Rates of anxiety, depression, PTSD, and addiction are skyrocketing. Why? The roots of these issues and more can often be traced to trauma, adverse childhood experiences, chronic stress, and ultimately, nervous system dysregulation. Meet your autonomic nervous system. Let's call it ANS. ANS takes care of a lot of your automatic functions, like your heartbeat, digestion, and body temperature. ANS also manages your survival and stress response, working to keep you alive when your life is in danger. ANS functions as our built-in detection system, constantly scanning our environment for cues of safety and cues of danger. As ANS scans the environment, it has 3 general responses or states. Safe. You feel calm, relaxed, and connected to those around you. Mobilized. When ANS detects danger, it sends a command and your heart rate and breathing increase, adrenaline and cortisol are released, and blood rushes to your muscles so you can handle the threat. This is our fight-flight response. Immobilized. When ANS detects that the danger is so great that you can't fight or run, it shuts you down. In this state, our heart rate, blood pressure, and body temperature decrease, and pain-numbing endorphins are released. ANS does all of this automatically without us thinking about it. ANS doesn't just use these states for survival, it uses them to navigate through the world each day. When ANS functions well, it moves fluidly from one state to another, 1 minute mobilized and ready for action, and the next resting and recovering. ANS will often blend states together. When we play, ANS combines the mobilized and safe states, and when we are intimate with loved ones, it combines immobilized and safe states. When ANS can stay flexible and fluid like this, it helps us manage and become resilient to stress and negative events. We're able to bounce back and move on. Unfortunately, when we experience trauma and chronic stress, it can keep ANS from functioning in a healthy, regulated, and resilient way, and can keep us stuck in states of survival. A friendly get-together can become frightening. A simple meeting at work can become threatening. For those with a history of trauma and chronic stress, the ANS detection system often becomes faulty, constantly signaling danger even when we are safe. It's like ANS is an alarm system, constantly signaling fire even when there's no smoke and no flames. Consistently living in these survival states can be debilitating, and we often develop adaptive strategies like using drugs, alcohol, food, work, or sex in an attempt to bring regulation and temporary relief.
Okay, so I'm going to stop there because the video kind of goes a little bit more into what Shale is going to be talking a lot about next week. I'm going to stop my share here. So why do I show you this particular video? Really because we can't talk about trauma and its impact without having a basic understanding of the autonomic nervous system and the brain. One of the things that I look at as a clinician and that I look at as a supervisor and when I'm providing guidance to supervisees is mobilized and immobilized states in the clients and constituents that we serve. When I look at a behavior through a trauma-informed lens versus solely an issue of, say, like motivation or somebody being resistant, for those of you who've been supervised by me, you know I don't like that word, or just looking at things as like a symptom of a disorder, there is a lot of information that I could be missing. So when I look at somebody through this lens, when I look at somebody and say, where is their nervous system operating? Number one, in that moment, I'm then going to attempt to co-regulate and kind of bring somebody back to a little bit more of a calm state. And then two, we're going to notice maybe how they got triggered, how their behavior in that moment, or what triggered their behavior in that moment, and how that could have been affected to their past experiences or past trauma. And I'm going to get a little bit more into this as I talk about trauma-informed care. So before I go on, does anybody have any questions? I realize that I'm kind of talking pretty fast, so I want to give a second for some questions or reflection if there are any. Okay. All right. Does not look like it, so I will go back to presentation. Okay. So how does trauma present? And again, I'm going to talk a little bit about it today. You're going to see more about this in next week and then the following week's presentations. So this is by Bessel van der Kolk. I'm sure a lot of people have been familiar with his book, The Body Keeps the Score. We have learned that trauma is not just an event that took place sometime in the past. It is also the imprint left by the experience on mind, brain, and body. The imprint has ongoing consequences for how the human organism manages to survive in the present. Trauma results in a fundamental reorganization of the way the mind and brain manages perceptions. It changes not only how we think and what we think about, but also our very capacity to think. So some of the physical and physiological responses of trauma or ongoing traumatic stress: GI distress, rapid heartbeat, issues with sleep, specifically non-restorative sleep, fatigue, long-term health effects, and it can change the way that a person experiences, perceives, and processes pain. Now, in a behavioral health setting, you may be, talking to somebody about coping skills for, depression they've had. You're also going to address, hopefully as like a holistic practitioner, some of this medical stuff as well. It's important to note that some of this medical stuff could be a result of some of the traumatic stress that a person has experienced, right? So again, we're sort of like broadening our view when we're conceptualizing, a person and what they have going on. Symptoms of trauma-related disorders in terms of behaviors and what might be present in a behavioral health setting. General dissatisfaction or unhappiness. So just always kind of like, I can't get happy. Nothing's right. Everything sucks. Difficulty experiencing joy or pleasure, where people really have a hard time just finding things that light them up inside. external anger and aggression, and dissociation. Just kind of quick note on here, it's dissociation, not disassociation. That's something entirely different. Dissociation is basically the brain's ability to shut off stimulus from the outside world and go internal. Dissociation is a very positive, protective coping mechanism, and it's on a spectrum. It ranges from mild, like daydreaming, when you're driving in your car to work and all of a sudden you're like, oh, I'm in the parking lot, all the way to losing large chunks of time. Trauma impacts the sense of self and a person's self-esteem, their ability to engage with others, and a person's overarching view of the world. Okay? So it's not only kind of right here in our own little microcosm, it expands even further. Some common diagnoses that might be seen in trauma. So both in youth and adults, we may see acute stress disorder and post-traumatic stress disorder. With adults, you may also see complex PTSD. Now, complex PTSD isn't a diagnosis in the Diagnostic and Statistical Manual, which is what behavioral health practitioners use to diagnose mental health related disorder. However, it is something in the ICD, I want to say ICD-10. So it is recognized in the medical sphere in some account, but not wholly yet in the mental health world. In youth, some other disorders that are often diagnosed as a result of trauma could be adjustment disorders, reactive attachment disorders, or disinhibited social engagement disorders. And again, I'm not going to go into a lot about this, what the diagnoses are. So here are other diagnoses associated with trauma or whose symptoms might look like this diagnosis, but might actually be something else. And again, when looking through a trauma-informed lens, for me as a clinician, when I'm seeing some of these diagnoses, I'm always looking for the presence of trauma regardless and the impact of the person and their sphere. But these are also things where I'm going to say, I might want to address traumatic history a little bit more. So personality disorders, borderline personality disorder, narcissistic personality disorder, antisocial personality disorder, dissociative disorders. So a big one that is associated with trauma is dissociative identity disorder. And there's also other dissociative disorders not specified. ADHD. So this is one that when people hear this, they're like, what? And I'm not saying, please hear me out. I'm not saying that people with a diagnosis of ADHD have experienced trauma. However, what I think is interesting is when someone has not necessarily had a full evaluation by a specialist, by somebody who specializes in neurodivergence or ADHD, and say maybe this is just prescribed by another provider who's not as adept in diagnosing ADHD. There's a lot of things that happen in the nervous system as a result of trauma that could look like ADHD, but actually aren't. So for some of my clients who have a history of ADHD, but have found that medication doesn't actually work for them, or they have a whole host of other symptoms in addition to symptoms of ADHD, that often points to a history of trauma or traumatic stress. Anxiety disorders, again, also diagnoses that could be associated with past trauma. Depressive disorders, substance use disorders, and eating disorders. Okay? So, and I kind of put this on here to say, again, if you're in a behavioral health setting, it is not just PTSD, CPTSD, and acute stress disorder that could point to trauma. It could be all of these other things as well. So how might these show up in behavior? Boundary issues. So having a client or consumer who has either really strict boundaries, so the person who sits there and is like, I'm not telling you anything, right? They're very rigid in their behavior and their interactions, or a person who's telling their entire story in really intimate details, not only to you, but to everybody else in the program. It might show up in behaviors to sort of dominate. So people who are trying to assert power and control either over the program or other maybe people in the program. A variety of protective mechanisms. So things like lying, things that we might view as manipulation, people who are, quote unquote, resistant, not showing up to treatment, people pleasing, which is also in the next one. There's a lot of different behavioral patterns that could occur in treatment that, again, could point to traumatic history and things that are being played out in the present. One of the biggest things for attachment and relational patterns that are played out, this could be, I have an example. So I have a client who I've been seeing her for about 3 years. If I could diagnose her with complex PTSD through the DSM, I would. But anytime we do very deep internal processing of a lot of past traumas that she's had, whenever we reach sort of a different or a newer part in her past, a day or two later, she is emailing me, asking me if I hate her, asking me if I'm going to leave, asking me if I'm going to stop working with her, because her anxiety gets so big. And she is so nervous, right? Because she's never had a safe relationship with somebody in which she could process these things, that I'm going to leave, right? Now, as a clinician, I'm not identifying her as clingy. I'm not saying, oh, she needs to just learn how to self-soothe on her own. I'm going to tune into that. And that type of behavior makes sense, right? So in behavioral health setting, we're going to see a lot of attachment and relational patterns played out, especially when people have not had the presence of safe relationships. And maybe you as a clinician or a peer, or the director of the program, become the safe person for them. You're also going to see hyperarousal. So basically when somebody is on edge of it all the time, they're constantly looking, they're constantly scanning for threats. They might be easily agitated, right? They might take a lot of what is said or done, either around them or to them, as kind of like a personal attack, right? Because this person has to be on edge, right? For whatever it is that they've experienced. Emotional dysregulation. So say you have somebody who there's seemingly something small that happens, and all of a sudden this person bursts into uncontrollable sobs and they can't calm down, or it takes them a really long time to calm down, right? So their emotions kind of might be, for lack of a better phrase, kind of all over the place because they have lower tolerance to handle big emotions. And then they might, this might also show up by a person meeting emotional and social needs in unhealthy ways. So they might start forming, if you run groups in your program, they might start forming unhealthy relationships with other people in the group. They might start engage in behavior. Things like substance use might continue, eating disorder behavior might continue, impulsive and compulsive behavior might continue. Okay. All right, any questions before I move on? Because I believe, yep, we've hit a little cute animal picture. So any questions before we move on? No, okie dokie. So now that we have kind of the definitions of trauma, kind of how it shows up, what diagnoses are associated in the behavioral healthcare settings, why do we need it? So a lot of this information was taken from SAMHSA. SAMHSA is the Substance Abuse Mental Health Services Administration. From their concept of trauma and guidance to a trauma-informed approach, they have a guide that is available for free online. So recognizing that trauma-informed care is an important component of effective behavioral health services. And it not only requires one agency, but it is really a public health approach. It requires public education and awareness, prevention, early identification, and then effective trauma-specific assessment and treatment. And in order to maximize the impact of these efforts, they need to be provided in an organizational or community context that is trauma-informed, which is based on the knowledge and understanding of trauma and its far-reaching implications. So trauma-informed care is different from trauma-specific services. It also does include trauma-specific interventions. So in my bio, I had included that I am a EMDR certified and IFS-informed EMDR basic practitioner. EMDR stands for Eye Movement Desensitization Reprocessing. That is a very specific trauma-specific intervention that I use with my clients to help process past trauma. IFS informed EMDR is also one of those. So that is trauma specific. Other types of trauma specific interventions could be exposure therapy, prolonged exposure therapy, narrative therapy, trauma focused CBT. Polyvagal theory has a lot of exercises for really managing the nervous system, and then as well as somatic experiencing and something called sensory motor as well. Also have particular exercises, activities, intervention to help address the impact of trauma. Trauma-informed care, again, includes these specific interventions. It is also present in the assessment, in treatment planning, in recovery support, and in discharge. And trauma-informed care incorporates key trauma principles into the organizational culture and policy. So to say that an agency or an organization is trauma-informed, and we're going to get into this, it's all-encompassing. It's in everything that the organization does. It's not just one person. It's not just one conversation. It's not just a monthly or maybe a, every quarter kind of, oh, we're going to address trauma. It's everything in the organization, which can be incredibly hard to do, especially when we get to areas like funding. So in my experience, there are certain things that on the way to organizations becoming trauma informed, there are things that are done or things that are put in place that could be trauma informed or could be a part of trauma informed care. But if they're alone by themselves, it does not mean that the organization itself is specifically a trauma informed organization. So this would look like trauma is only being addressed at intake, right? So when a person comes in, maybe they are asked about, and again, this is behavioral health settings, but they're asked about their history of trauma. I kind of want to make a caveat to this. Often when people are asked about trauma, they're asked specifically about those acute traumas, right? So very specific events or PTSD, like if they meet symptoms of PTSD. So now what we've learned so far in this presentation is trauma isn't just acute trauma. It could be a whole host of different events that someone experiences. And PTSD is not the only diagnosis that could be given to someone who's experienced trauma. Right? So if an organization, asks about it on intake, they're like, okay, hey, cool, we're going to ask about trauma, we're just going to see, but then nothing is done with it after that. That alone is not trauma informed. Having trauma specialists on staff. Again, this is a great step to becoming trauma informed. But what tends to happen is when there are only a few staff on site who are trauma specialists, meaning they've been trained in trauma specific interventions or really trauma informed care, every client, every consumer with trauma is then funneled to them. Now, as a part of trauma informed care, it also means taking care of staff and understanding vicarious and secondary trauma. These staff members who are trauma specialists, they're probably going to have a higher burnout rate than maybe some of the other clinicians, right? And again, they could be working with a trauma specialist, but still experience other things in the organization or the program as a whole that is re-traumatizing. Another thing that often happens, and again, this is a great step to take, but standing alone, it's not necessarily trauma informed when there is the trauma group, right? So there's maybe a group on the schedule, say if this is an outpatient or intensive outpatient program, that everybody who's identified that they have trauma at intake, we're just going to put them in the group, and you're all going to sort of process and learn coping strategies together. This can be a really safe space potentially for everybody in the group, but however, if other groups and other clinicians do not understand the basic principles of what it means to be trauma informed, don't understand what trauma looks like or how trauma presents, you could go to the trauma group, but then if you're going to all these other groups, you might still be experiencing re-traumatization. And then finally, your analysis collection. So if you're in a behavioral health setting where you are providing regular drug testing, and this is kind of a controversial topic, is collecting drug tests actually trauma informed? but you are saying that everybody who has to submit a drug screen has to be observed or else it's a failure, has to be with a particular staff member, and are not supporting people who don't want to submit a drug screen in front of somebody else, right? That can potentially re-traumatize somebody. So trauma-informed care, we're getting onto the 4 R's of what trauma-informed care looks like. So first is realize or realization. Sorry, I'm just finding my notes here. So all staff, from people at the front desk to the clinicians, to management, to the CEO, to the board, understand the impact of trauma on the individual, on group, on communities, on organizations, and understands the implications of trauma. It makes sense. Now, because all staff in that organization understand trauma and it impacts, they're looking at behavior through the context that coping mechanisms are meant for survival and protection, right? So, oh, of course, say, I turned off the lights to play a clip in my group, but somebody has a specific incident in their past where going into darkness really quickly triggers them. And all of a sudden they freak out. They stand up, they start to cry, and they run out of the room. And they refuse to come back because in that moment they were triggered and they had a response. I'm myself, the people at the front desk, the people who then intercept that client are going to understand, this behavior makes sense. This person has a trigger related to turning off the lights or being in sudden darkness. Of course, they're going to be flooded. Of course, their fight or flight mechanism is going to kick in, and they're going to do whatever they need to do to get out of that situation. Right? All staff members understand that trauma plays a role in mental health and substance use disorder treatment, and it is consistently addressed. And all staff understand that trauma is not only showing up in the behavioral healthcare setting, but it's showing up in other systems, and a person's experience of trauma is also going to impact their success in other systems as well. Second R is recognize, right? So all staff, again, they're going to recognize the symptoms and the signs of trauma starting at assessment. They're going to recognize how trauma may show up differently across cultures and how it may present differently in varying demographics. All staff is also going to understand how systems of oppression and people who hold marginalized identities may experience different traumas than those who do not hold the same types of identities. And that's going to be discussed and taken into consideration. That's supposed to say front desk to CEO, but again, all staff are recognizing this. And this is something that is consistently addressed, not only with clients and consumers, but among staff. So if we're gonna use that example that I used on the last slide, I turn off the lights, a client has a response, leaves the room, say somebody at the front desk intercepts and has a really hard time helping them de-escalate. Eventually the situation is settled. A supervisor or that person's direct manager is then going to follow up with that staff. That supervisor is then going to follow up with me and say, hey, how was that for you? How are you feeling about what happened? Did that bring anything up for you? How do you need to take care of yourself? So it's not only being addressed in consumers and constituents, but also with staff. The next one is the response. Again, all staff, I can't say it enough. This one is tough, and I just kind of want to read this statement from SAMHSA in terms of how all staff respond. The program, organization, or system integrates an understanding that the experience of traumatic events impacts all people involved, whether directly or indirectly. Staff in every part of the organization, from the person who greets clients at the door to the executives and the governance-based board, have changed their language, behaviors, and policies to take into consideration the experiences of trauma among children and adult users of the services and among staff providing the services. So it's even in the language that is used. So how they respond, part of this means is that all staff is trained. All clinicians are trained in trauma-specific interventions, not just one or two, all of them. Staff who are not providing clinical services are then trained in what is trauma-informed care and what is the impact of trauma. What does it look like, right? So they might go to a presentation on adverse childhood experiences. They might go to a presentation on the neurobiology of trauma. And this is covered in the budget. Now, this is an issue, right? Because we know, especially if you are a grant-funded organization, and this is where it needs to be even larger, you may not have money in your budget to send all of your staff to these, and this, I'm going to get on a little bit of a rant around accessibility, these expensive ass trainings so that all of your staff can address trauma, right? And then that becomes an even bigger issue, is that honestly, these trainings should not cost you your entire savings in order for you to attend them. But anyway, that being said, this is something that is in the budget. It is also something that is written in policy, right? You see it in the language across policy and procedure manual. And again, this is not only in the people who have direct contact, but in leadership, advisory boards, and in supervision. And the last R is the organization does everything that they can to resist re-traumatization. But when re-traumatization does occur, they know how to address and approach, again, not only clients, but also staff. Some things that are in various organizations that have sort of like I guess that are more known to re-traumatize, things like urinalysis collection, putting somebody in restraints, abandonment issues, and then relational issues between therapists and clients, right? So these things are addressed in their policy and procedure manual, how it's handled during, and then how it's handled after. And then finally, so this is, although this says it's from the trauma-informed organ, this is also taken from the CDC. These are just the guiding principles of trauma-informed care, a little bit different than the 4 Rs, but there's a lot of overlap. Basically, organizations are constantly putting things in place to ensure that there is physical and psychological safety among all people in that organization: clients, constituents, consumers, staff. There's trustworthy, and they are transparent. Organizational operations and decisions are conducted with transparency, and the goal is to build and maintain trust among the entire community of people receiving the services. They also understand the importance of peer support and mutual self-help, and this kind of goes into collaboration and mutuality. And I kind of want to say this, I'm a clinician. I've been in the behavioral health field for, since 2006. The behavioral health field and the mental health system has 100% caused harm to people, right? And, for me to just say, well, everybody should get therapy and find a therapist, is really dismissive of some people's experiences who've been harmed in therapy, right? So, however, what I say is that healing happens in the context of safe relationships. A safe relationship might not mean a therapist. It might mean somebody in a spiritual group, in the community, a religious affiliate, in a religious group, a peer support, right? So yes, while I believe that my services are really important that I provide, I also know that people aren't necessarily going to heal in therapy, right? There's a whole host of other things that need to be present to support the healing of that person. They also understand in regards to peer support that it really empowers people. And I say this when I'm supervising peer coaches all the time, is as much as I think like I do a really good job at being on a person's level, there's always going to be a power differential because of my title, right? And people need to have support that is not just a therapist that has this sort of inherent authoritative kind of view, right? So they need self-help, they need, or rather mutual help. Empowerment, voice, and choice. So the organization aims to strengthen the staff, client, and family members' experience of choice and recognize that every person's experience is unique and requires an individualized approach. Right? So really inviting in a client or a consumer to make more informed choices about their treatment. That means that they're going to sit down and say, hey, here's what treatment typically looks like. Here's what, if they're coming into an intensive IOP treatment, I'm going to talk to someone and break down what that means, right? What they can expect. I'm going to orient them to the program, and I'm going to do that pretty consistently. So for example, when we started, I not only had an introduction of who I am, I not only stated objectives, I said to you, hey, listen, there's going to be slides, a video clip, more slides, and questions. So you knew what to expect. And then the last one, cultural, historical, and gender issues. So the organization actively moves past and addresses cultural stereotypes and biases, offers culturally responsive services, leverages the healing value of traditional cultural connections, and recognizes and addresses historical trauma. So these are organizations who also kind of put their money where their mouth is in terms of DEI, right? And recognizes that, again, this is also something that is consistently addressed throughout the course of treatments. All right. Finally, I leave you with sloth. I leave you with this cute little picture. Okay, so it is 12:49. I'm going to stop sharing. I would invite everybody to just kind of take a moment. We have 10 minutes left that I'm going to use for just questions, feedback, any thoughts that come up. But before we do that, I want everyone just kind of take a moment wherever you are. And I just want you to take a deep breath in through your nose. Exhale out. And just kind of bring your awareness inward for a moment. Maybe noticing your own heartbeat. Maybe noticing any bodily sensations as you sit or lie or stand wherever you are. Kind of notice any emotions or responses that might have come up during this presentation. Notice any thoughts, any disagreements, arguments, anything that may have come up during this. And just take a second to really hold your entire experience, right? Not saying that's bad or pushing it away, just acknowledging, ooh, I feel this. Ooh, I think this. Wow, this emotion is present. Take a moment to hold all of that. And then once more, taking a big breath in. And a slow release. All right. So I will take this time to kind of open it up to all of you, see if there are any questions or anything that any of y'all might need.
Good afternoon, Monica. Can you hear me okay?
Yes, Brezhnev.
How are you? Good to see you again.
You too.
My question to you regarding trauma, as a clinician, right? Where do you make the distinction or distinguish between something that's traumatic to a clinically significant degree, or it's just a natural human reaction to a negative circumstance or situation?
So if I'm being completely honest, Brezhnev, all of our traumatic responses are appropriate, normal responses to trauma. So when I look at coping mechanisms, I look at every single coping mechanism as what was the initial intended function of the coping mechanism and how does it protect someone.
Okay.
So I'm always looking at it as, hey, this is something that transpired as a result of the trauma. And if I were to kind of break it down enough, it's going to make sense as to why it's there.
Gotcha.
I have a question.
Yeah.
So we have prevention consultants on our team as well who are going in and doing prevention presentations. How can they take this into their work while they're presenting?
So I think one of the things that I attempt to be mindful of, and I have to be honest, it's a little bit harder for me to do over Zoom than it is in person. I really try to be very mindful of the language that I use. I really try to be very mindful that I don't know what it takes for every single person in this room to feel safe and secure. However, I'm going to try to do as much as I can to make this like a comfortable space for people, right? So that means that I'm going to, again, tell people what to expect, tell them who I am. I'm going to put little breaks in there, and I'm also going to acknowledge the potential heaviness of the content, and also acknowledge that everybody's going to have a different response to the content. So that's kind of what I would say is those general guidelines. Everyone's just taking it in. Hopefully people were able to eat too during this. Like, eating always helps you retain information.